Dear colleagues, welcome to the first EACTA webinar entitled Routine Cerebrospinal Fluid Drainage for TEVAR. Let me introduce myself. I am Purificación Matute from Barcelona, Spain, and I am the present chair of EACTA Vascular Subcom. It's a great honor for me to chair this first webinar. Firstly, I would like to thank Dr. Mohamed El-Tahan for organizing and coordinating this presentation. And also, I would like to thank the moderators and speakers for their collaborations to talk about this interesting and exciting topic. All speakers are experts in this subject. Now, I would like to introduce Dr. Dragana Unik Stojanovic from Belgrade and Dr. Simon Howell from Leeds, both are delegates for Vascular Subcom, who will introduce the rest of the speakers and moderate this panel. I hope you enjoy and clarify everything about this topic. Thank you very much for your attendance, and please, Simon and Dragana, present and introduce the next speakers. Thank you very much.
Fucci, thank you very much indeed for that. It's my pleasure to be one of the joint moderators for this first EACTA webinar. The objectives of this webinar are to update you, the audience, about the current evidence and best practice for routine CSF drainage, and to promote and rehearse the practical skills required for CSF drainage and appropriate decision making around that procedure. The webinar consists of 4 talks. Move on to our next speaker, the first of our pro-con talks about spinal cord drainage. And it's a pleasure for me to hand over to my co-moderator Dragana to introduce that talk. Kavita, thank you very much indeed for those questions and answers and for a fascinating talk. Kavita, may I hand over to you? Sorry, Dragana, may I hand over to you?
Thank you, Simon. Good evening from Belgrade. Now we can move to our next topic, and I would like to introduce our next speaker, Professor Daniel Bolliger from University Hospital Basel, who will talk about pro-factors for routine cerebrospinal fluid drainage for TEVAR procedure. Daniel, please.
So, hello, good evening everybody from Switzerland. I hope you can understand me well. So, first of all, thank you to the organizers who invite me to give this talk. I have no conflicts of interest to declare. Now, in a pro-con debate, which I have with Balthasar Eberle from Bern, so one has to take the clear yes position and the other one has to take the no position. And in real life, of course, it's often not that clear. It's not black and white, but it's a lot of gray zone. So we have a bit yes, a bit no, and sometimes it's a bit more yes, and sometimes it's a bit more no. But for this talk, I have really to take the yes position. So, as we heard from Kavita, the most devastating complication of the open TAA and after endovascular repair of the aorta is paraplegia. And the incidence of paraplegia or spinal cord ischemia after open TAA surgery has been reported to be between 2.5 and 40%. Whereas generally it is assumed that TEVAR procedures have lower morbidity and lower mortality, the incidence of spinal cord ischemia is still between 0.5 and 10%. So that despite generally lower risk, the incidence of the most serious complication seems to be similar. And this is just to show you general what is the risk of spinal cord ischemia in TEVAR? This is a systematic review from Archer in 2016, and what he included were 22 studies, including about nearly 5,000 patients. And in these studies, the authors used either routine prophylactic CSF drainage or selectively prophylactic CSF drainage, or rescue CSF drainage after surgery. So overall, the reported incidence of spinal cord ischemia was between 0 and 7%. And interestingly, if they included only the studies with prophylactic drain placement, the rates were still between 0.75 and 6.6. So there seems not to be a really difference between patients with prophylactically insertion of a CSF drainage and patients with a rescue insertion of a CSF drainage. So when we use CSF drainage, we can either do this to guiding the spinal cord perfusion pressure, as we have heard from Kavita, that the spinal cord perfusion pressure is the most important determinant of the spinal cord ischemia, or we can use it to avoid the catastrophe, so to really avoid paraplegia. Now, risk factors for spinal cord ischemia after TEVAR, we have heard from Kavita. They are either demographic, so they include age, a higher age, lower BMI, renal failure, or previous aortic surgery. Of course, anatomical characteristics play a role, so the extension of the aortic disease, the type of aortic pathology, if there is a dissection or rupture, if it's emergency or a scheduled case. So our intraoperative risk factor may play a role, so the duration, as long as the duration of this intervention, the higher the risk for spinal cord ischemia, the stent coverage, and the number of aortic stents used, and also post-operative risk factors. So we heard from Kavita also that there is a special danger zone where the highest risk of spinal cord ischemia is. So if the surgeon has to cover the upper part of the thoracic aorta, or especially the thoracic part of the aorta, there is a special high risk of spinal cord ischemia. And there are different strategies that have been developed to avoid spinal cord ischemia in open TAA surgery. So, for example, to minimize the spinal cord ischemia time by using left heart bypass, or by using distal perfusion, the so-called God shunt, to increase the tolerance of ischemia by using deliberate hypothermia or deep hypothermic cardiovascular arrest, to use selective spinal cord hypothermia or pharmacological neuroprotection to augment spinal cord perfusion, or to early detect spinal cord ischemia by using MEPSEP and, of course, postoperative neurologic examination. When we go now to TEVAR procedure, only part of these strategies are feasible. So we can use deliberate hypertension, we can use CSF drainage, and we can use serial postoperative neurological examination. Of course, some centers use intraoperative MEP and SEP, but there is not a general advocate to use such techniques. So when we go now to the spinal cord perfusion pressure, which is the most important determinant of spinal cord ischemia, it is defined as the collateral network pressure minus the spinal fluid pressure. And to simplify it, it's the mean arterial pressure minus spinal fluid pressure. And so when we want to affect this on one of these two factors. So we can use either a deliberate hypertension. However, there has been no studies showing a positive effect of using hypertension, even if it makes sense, of course, but there's no study who showed that it's really beneficial to use a higher pressure to avoid spinal cord ischemia. And the second one is therefore we can mainly reduce the CSF volume. And to reduce the CSF volume, we can use CSF drainage. And now we really do not want to play with the spinal cord perfusion pressure, but we will avoid the catastrophe, so we will avoid paraplegia after aortic surgery or after TEVAR. And when we look now at the guidelines, and this is another guideline which has been published in 2010 by the ACC FAA, and what they say that CSF drainage is a spinal cord protective strategy for open and for endovascular thoracic aortic repair, and they say it's a 1B recommendation. So this means that the benefits of CSF drainage is much higher than its risk. And this is especially true for patients with high or higher risk for spinal cord ischemia. However, the real number to treat to avoid a spinal cord ischemia or to avoid a paraplegia is unclear at the moment for open procedure and also for TEVAR procedures. So, is the CSF drainage really effective to reduce paraplegia? There are several anecdotal case reports showing that after a rescue CSF drainage, the patient moved again his legs so that the paraplegia went away. And there is a new systematic review from Epstein showing that there is a reduction from paraplegia from 20 to 2.3% in open TAA surgery and TEVARs by the using of CSF drainage. So this is really a good number that we should use it. However, we have to say in this review they included open surgery and TEVAR. And when we want now to look, and the most of these studies were retrospective or cohort studies. So if we really want to look, is there a randomized controlled trial? There is only one, and this is in open TAA repair, published by Coselli in 2002. And what he showed in open aortic surgery, that the prophylactic CSF drainage significantly reduced the risk of paraplegia from 13% to 2.6%. However, no randomized controlled trials in TEVAR procedure. So, going further, there is some further evidence, and this is a systematic review from Wong, and he included now 36 studies, including nearly 5,000 patients, and he reported an overall incidence of spinal cord ischemia of 3.89%. And interestingly, if he included only studies with routine prophylactic drain placement, the incidence was a bit lower, 3.2%, but not really much lower. And if he included the rates, the studies with selective prophylactic drain placement, the rate was, or the incidence was even higher, 5.6. However, these studies included patients with a very high risk. And when we look now at studies with no prophylactic drain placement, the rate was 3.5. So this may again be explained as in the later studies with no prophylactic drain placement, the risk for spinal cord ischemia might be relatively low. So that's may explain why in these studies the relative incidences were rather similar. And the authors had to conclude that the role of prophylactic CSF drainage in TEVAR is difficult to establish from the available literature. Now, there is another systematic review from Kahn in 2016, and what he investigated was whether CSF drainage decreased the spinal cord, the risk of spinal cord.
A lot of work for the speakers. So on behalf of the board, I would like to say that we are really indebted to them because they were really very brilliant and so committed to this webinar. It is my pleasure also to thank the EACTA Vascular Scientific Subcommittee, and in particular I would like to thank Dr. Purificación Matute, who was the chair of this webinar, and Simon Howell and Dragana Junic, who were the excellent moderators of this webinar. Also, I think that a special thank has to go to the Social Networking Task Force and to MCI for advertising the webinar. And last but not least, a special thank to the committee of EACTA, and in particular to the chair, Professor Mohammed Al-Tahan, whose effort made this webinar possible. So really, thank to all these EACTA people who worked very hard on this project. And a very, very special thank goes to all our friends and colleagues connected from all over the world for attending the webinar and making this webinar possible. We could have excellent speakers, but with no audience, the webinar would not be a success. And then I take the occasion to announce the next EACTA webinar from the Thoracic Scientific Subcommittee, which will be held on March 25. So please mark your calendar on March 20. We'll have a very interesting webinar held by the Thoracic Scientific Subcommittee. So thanks everybody for joining and participating, and see